Habari za mchana. We welcome you to today's session. This is the Dr. Saria's Oxygen Therapy and Critical Care, the case-based series. And this is session 6. And these are some few housekeeping items to remember as we start our session. We will be using the chat function for question and answers, which is also feel free to introduce yourself. We also will be using the chat function during the session, so keep the session interactive and respond through the chat function as well. If you have any IT issues, you can also send a message through the chat. And also remember that this session is being recorded and your attendance is consent to be recorded. And just a reminder of our sponsors, this session is brought to you in collaboration with Assist International, Stanford Medicine Division of Global Anesthesia, University of New Mexico Health Science Institute, and the Global Anesthesia and Critical Care Learning Resource Center. So we welcome you. I will now welcome Dr. Saria to introduce the panelists in the session today. Welcome, Doctor.
Okay, thank you very much, Dr. Kevin. So my name is Dr. Peter Saria, anesthesiologist working at CCBRT Hospital in Dar es Salaam. And today I would like to introduce the panelists. First, we have Dr. Rebecca Samuel. Dr. Rebecca Samuel, she's an anesthesiologist at Bugando Zonal Referral Hospital. We have also Dr. Leticia Komba. She's an anesthesiologist at Mbeya Zonal Referral Hospital. Currently, she has not joined, but I'm sure she will join us later during the session. And also we have Dr. Gibbons Makisambwe, who is currently, he's an anesthesiologist also working at Mbeya Zonal Referral Hospital, but he's also currently doing his Master of Science in Critical Care at Muhimbili University in Dar es Salaam. So this will be our panelist. And as Dr. Kevin said, today we're going to discuss about the basic needs for ICU care. We are all aware that the government of Tanzania is in the process of installing ICUs to all the regional hospitals and, if possible, district hospitals. So this will be a very good topic, or it will be a starting journey toward the establishment of these ICUs. So Kevin, without any time, maybe we can go direct to the agenda. If you can share from that side, please. Okay, so this will be our, can you scroll up so that you can see the objective? So this will be our objective of the day. We have to identify the minimum standard for an ICU care unit. And then we have these sub-objectives, as you can see there. We'll also list the most common indication for ICU admission, understand and prevent the most common complications that can occur in ICU, and also we'll review or we'll have a plan or develop an implementation of ICU care bundle. We'll see what are these care bundles, and for those hospitals which they don't have these bundles, then we'll discuss a way forward to ensure that each hospital has these care bundles. So my task will be just to share with you a case. Scroll from there so that you can see the case. And then I will welcome Dr. Rebecca to proceed. So our case is Mr. T, who is 46 years old, male with a history of obesity and type 2 diabetes mellitus, who present to the emergency department after 3 days of shortness of breath, cough, and fever. And after examination, he appears well. His breathing is non-labored, and he is speaking in a full sentences. And in the past surgical history, he undergone laparoscopic cholecystectomy in 2012. And social history: no smoking, drinking, or drugs. Lives with multiple family members. Works in an office as a water engineer. So when when the vitals were taken, the heart rate was 98 with a blood pressure of 127/63, and respiratory rate of 30, temperature 36.5, with his oxygen saturation of 87. So the plan, he was placed on a non-rebreather mask at 10 liters per minute, and his SpO2 improved to 92%. And then the emergency room physician placed a call to the on-call ICU physician. So this will be our guide case. We will go with this case until we finish our session today. But beginning, now I would like to welcome Dr. Rebecca. So Dr. Rebecca will take us through to know the definition of ICU, the minimal standard, the monitoring, the staffs, and whatever, and all those which are necessary in the establishment of an ICU. So Dr. Rebecca, please, you may continue.
Okay, thank you so much, Dr. Saria. As I've been introduced, my name is physiologist currently working at Bugando Referral Zonal Hospital, and I'm going to take you through this first part of our presentation. And let me remind you, as we have always been doing, it's an interactive session. So I don't expect to be much speaking, but we will always interact. So whenever I need your interaction, please, feel free to come to join and come in and comment on anything. As you can see, that's a very complex picture or image in your screen. That is the summary of what is an ICU. So an ICU is I can say is a complicated thing, with a complex unit in which it involves a lot of multiple specialties or interprofessionals to provide care to patients, and there are a variety of care which are being given to the ICU. So that's in that unit, there are a lot of care. So they have been summarized, but I cannot read all of them. But I can say that the issue of monitoring, patient monitoring is there. We are monitoring the functional vital capacity of the patient, including the vital signs, but also organ support is being provided in ICU, and we shall know more what all those organ support being provided in ICU as we go on with our presentation. So basically, we can say that ICU is an organized system for the provision of care to critical ill patients that provides intensive and specialized medical and nursing care. But the more on monitoring and the other multiple modalities, including organ support, as I have said. And more for those patients with organ support. And as we shall go on, we shall see that it's a multidisciplinary or interprofessional. So we need, in order for ICU to be functional, we need a team, and this we shall discuss more when we are going on. So there's one thing being written there, that the critical care is a moment in time. It is a delivery of care that is time critical. So critical care services need to be delivered in time, or need to be delivered in time. As we all know that whenever the patient is in need of critical care, that's the moment that patient need to get that service. So whenever you delay to provide the critical care, then that patient will always succumb with complications. So you need to be very, very careful in providing these critical care services. So that's in a simple way, that's the definition of ICU. And in this section are actually the package change action items to identify the minimum standard of an intensive care unit. I have already defined what is an ICU. So that's the definition was according to the World Federation and the critical care. So that's the definition we have seen. So let's proceed. Now that's the definition I have.
Hivi Saria atanitumia uone hapa alinitumia.
Let's move on.
Remember
because we have
to mute
the
yourself.
definition. There's a question there. Which of the following are standard components of an intensive care unit? Now, here I need a response from you. So be free to post on the chat the letter of the answer you think is the correct according to you. There's number 1 up to number 6. So you feel free to write any number you think that will be the correct answer. So which of the following are standard components of an intensive care unit? There's continuous monitoring, specially trained healthcare providers, system for delivery of time, critical care, specialized patient care equipment, rapid access to diagnostic, and all the above. I have seen one response. Okay. Okay. Saria, can you help me to check?
Okay, Rebecca. Okay, so there are 5 responses from participants. So majority of them are responded number 6, which is all of the above. We have Namala Mkopi, we have Juliana Njole, Ntiga Leonard, and Kana Shibon. All of them, they say, they respond to option number 6, which is all of the above.
Okay, so thank you so much for those who have responded. And definitely, if you see, we shall see now what are the standard components. Yes. Kevin, let's go on. So as we discussed in the previous session, that critical care is a continuum. I think this now word is familiar from the previous session, but critical care has to be continuous. And the critical care is time critical care, and they can occur everywhere. So as I said, it should be provided timely. And as we discussed in the previous session, we said that critical care is not necessarily to be provided in the intensive care unit, but can be provided even outside the ICU. This one we discussed. But generally, globally, there is a critical care capacity has been neglected. And now there is a need of global needs for essential emergency and critical care. So now we are really focusing on developing essential emergency and critical care for most of the healthcare providers. And we know that critical care services are needed everywhere, not only in intensive care. So there are different, I can say, guidelines or different reviews according to different societies, like there is a global need for essential emergency and critical care, in which they have defined the basic component of the ICU. They have defined what is an ICU, what are the composition or services being provided, and what are the levels of ICU. For the sake of time, I won't go through all of them, but we can share with the participants so that they can see the details and see what is the variation between the global need for essential emergency critical care and essential emergency critical care. Okay. I don't want to go into the details, so just share with them. You can share with the participants. So basically, if you go into the details, they have every society has defined the ICU and has already stated the composition and the different services being provided in the ICU, and has also defined the levels of the ICU. So quickly, when we say that we'll go just straight to the services, or the components, now the basic components of intensive care units, I will just go quickly on the 5 things. And a standard ICU need to have enough space. We need a physical space. So the ICU need a space to accommodate machines, such as ventilators. Sometimes some ICU, some advanced ICU, they have dialysis machine, they have suction machine, but also accessibility to patients. So in one bed, there has to be enough space to accommodate staff during the resuscitation. So the space has to be enough. But also the ICU has to have enough space for isolation, and we always have negative pressure. but also the central nursing station for monitoring patients. The ICU has need to have stores, offices, and the staffing area, like counseling area. But also services or supported monitoring technology. Every ICU needs capacity to do respiratory support, hemodynamic support, renal support, and the nutritional support. Those are the few services among so many services which are being delivered to the ICU. But also, in order for the ICU to function as a standard component, it needed human resources. So as you can see in the question, they say special trained healthcare providers. So we need trained healthcare providers to give services to these patients. So now these healthcare providers, they are multidisciplinary. So they are not necessarily nurses. They need to be nurses. They need to be doctors, physicians, anesthesiologists, intensivists. We need a pharmacist. We need nutritionists. We need other cadres like biomedical engineers. We are having equipment for services. So it's all those providers, they need to be in ICU for care provision. But another thing is we need also to have now the services. There are so many services which are being provided. As I said, respiratory support, that's the basic and advanced respiratory support, neurological support, nutritional support, circulatory support, and the other support which are being provided in the ICU. So, but also diagnostic services need to be accessible. So according to this question, all the answers were correct. So let's move on, Kevin. So now back to our patient. Okay, so the practice change of action is to identify the key healthcare provided in the intensive care unit. Looks like I've preempted this question. So let's update our case. Our patient was kept on oxygen 10 liters, and initially we saw that the saturation improved to 92. But now, despite being on 10 liters, the saturation has decreased. It's decreasing to 89%. And then now his respiratory rate has increased to 32. Initially it was 30, now it's 32. And he's only speaking 2 to 3 words at a time. Initially he was in full sentence, now in 2 to 3 words at a time. Now you can imagine what is happening to this patient. So now the question is, does this patient need the ICU? Now I need a response from you. What do you think? Does this patient need ICU anyway? And then you tell if it's yes, why? And if it's no, why? So like some few seconds, you can just write, you can type on your chat box, then we shall see the answer. What do you think with this condition of the patient? Does this patient at this stage need an ICU or need to be in ICU? What do you think? Does anyone with any idea, any concern, any comments?
I think chat has been disabled, so we cannot contribute through the chat.
Thank you.
Okay, Kevin, can you take care of that, please? Seems like we have disabled the chatting function.
Echo India team, Alvin, we can't seem to use the chat function.
Oh, let me just see it.
Atinamara, can you just speak?
I think we cannot just use these few parameters to make that decision. Again, I would rather have blood gas analysis to determine whether this patient need advanced care than what the patient is receiving. But definitely, he at least require high care at this moment in time until we determine other factors that the patient has. But definitely, it seems like he's getting more respiratory distress, and this patient might require intubation because he's not getting better.
Thank you so much. Can we get another response from anyone? Okay. Okay, now the chat has been is okay, so you can just drop your answer through the chat box if you have. Okay,
Yes,
Privatus.
can you- Okay, I think he's having a problem with network. Maybe Rebecca, you can proceed if you have time.
Okay, let's proceed because of time. Yeah, very good. So, of course, Dr. Namala has spoken something very crucial that these vitals we're having, probably they're not very much enough to tell us on the ventilatory status of this patient. But by just looking on the way the oxygenation is, that he's on 10 liters, and initially he was improving, but now on the same flow, is deteriorating. So this patient need very, very close monitoring. And therefore, in our setting, because we know our setting is more highly advised, this patient need to be under close observation, and mostly in ICU ventilatory support. So I think it's better you decide to make arrangement for this patient to be in ICU so that for close monitoring of ventilatory status, and in case he continue worsening, then it's very easy to take over with the ventilation, say like that. So this patient fits some criteria for ICU admission. Though again, if you have an advantage due with a very good monitor, the people who are keen to monitor the patient, you can still observe for some time, but definitely by the trend, this patient might need intensive care unit. So another question was, which of the following are essential staff for ICU? It's also a question. So, and because I have preempted this patient, I think now it's very easy to answer. So just write a letter of the correct answer you think in the chat box, whether it's number 1 up to number 6. Feel free to write whatever answer you write. We take it positively. We just appreciate your answer. So feel free to write anything on the chat box. Just 30 seconds for this one. Yeah, I have not seen any response up to now.
Chat has been disabled again. So.
Oh, okay. There are 2 hands being raised. Privatus, can you now speak? Oh, it was a previous hand. Privatus. If you can hear me. Hey. Number 6.
No, he's saying he has been disabled. I think also we should not hesitate to speak any language, please. If you feel comfortable speaking Swahili, please just respond in Swahili. Wote tunaongea Kiswahili hapa, kwa hiyo ukiona unahitaji kuongea kwa Kiswahili usiogope, wote tunasikiza Kiswahili vizuri kabisa.
Okay, so I have 2 responses from Nasoro Hassan, Juliani Njole, Privatus. Thank you so much for your responses. They have all written number 6, which is all of the above. So I think this one is straightforward. As I said initially, that in ICU, ICU services are provided by different people with different professionals. So the ICU patient needs multidisciplinary team to care. So including ICU trained nurses, ICU trained physicians, respiratory therapists, physiotherapists, pharmacists, cleaners. We need all of this. We need psychologists sometimes we need biomedical engineering to take care of our equipment. We need a nutritionist. So we need everybody to take care of these patients. So all patients, all these services are essential for ICU patients. Let's proceed. Kevin?
Maybe Rebecca, just to emphasize on that, as you
Yes.
say, it's a multidisciplinary team approach when you're carrying the patient in ICU. And I would like just, Kevin, can you share again the document we are trying to share? Okay, so this is from the College of Intensive Care Medicine of Australia and New Zealand, which was published in 2011. But as you can see from this document, when you go through it, you'll see there's a definition of an ICU, as Rebecca has already spoken about it. But also we have seen it has a general requirement for intensive care units, the staffing, the medical staff, the specialists who are required in ICU depend on the level of the ICU, the nursing staff, the ratio. So all this document which Dr. Kevin is sharing the links, you can just go through them. You'll get a lot of information which you cannot cover during this 1 hour presentation. The issue of structure of an ICU, the equipment which are required as the basic. Kevin, can you just hold on the equipment? So the basic equipment should be included, as you can see. These are just are not limited, but at least we should have the ventilators for invasive and non-invasive ventilation. We have hand ventilating assembly, suction apparatus, vascular access equipment, monitoring equipment, defibrillation, which is almost not available in many setup, but maybe, who knows, maybe soon we'll have these equipments, the infusion pump, specialized pump. So just go through this document. I'm sure you'll get a lot of information. Dr. Namala, please, you can just speak.
Yeah, I was just wondering, does the above document needs our input or contribution of any kind? Because if that is the purpose for this document, then it would have been nicer if it would have been shared a little bit earlier so that we can have something to talk about in this presentation. Otherwise, it's very difficult for us to have any contribution on the document for this purpose. I was just wondering, and yeah, that's what I wanted to say.
All right, thank you very much for your concern. For sure, we were supposed to share this document. All these documents have been shared through the Learning Center. Maybe you don't have the access to that email, but we shared the email, this document, all the participants who shared the emails earlier. So all these documents are available in that Learning Resources Center, which which was shared in through an email. But we are not supposed to contribute anything, but it's just for as an additional document to cement what we are trying to discuss this evening.
Okay, noted.
Okay.
I guess I was omitted on that email.
Thank you.
We'll take care of that, please.
Pole Namala. Okay, so I think Kevin, this document will come later. We shall go through it again. So here we are just seeing the minimum, and just in addition to what Saria has said, if you go through that document, it is stated the staffing according to the levels of ICU. As I said, that if you go through the document, there are levels of, there is a level 1 up to level 3, according to the advancement of care in those ICU. So even according to the level, it depends on the level of ICU. Now, even the staffing varies according to the levels. All those information, if you go through the documents, they are there. So if you level 1 ICU, so we have been discussing. Now, going back to Mr. Tin's condition, what do you think? Among those staff we have been discussing, who can improve the care of Mr. T? which among those, the pharmacists, you have nurses, we have physicians, we have therapists. Whom do you think is a very specialized provider that can improve Mr. T condition? You just write, feel free to write. Yeah, you do think pharmacist, maybe a nurse, critical care nurse, or do you think? Feel free just for 30 seconds. I think now the chat box is free, anybody can drop anything. Whom do you think can improve? Which of the above provider could improve Mr. Care? Okay, Raymond Makoma, thank you. Dr. Rikana, thank you so much. I've seen your response. So the two who has responded, basically they said all of the above. And I think, okay, thank you, Nasoro, as well. Thank you, Kanoni Mwanjara, Privatus, Asante. So nobody has mentioned only one provider. So this means that it's a teamwork. So the ICU trained nurse alone cannot make it. Even the ICU trained physician alone cannot make it. So we need to work together. It's a teamwork, it's a multidisciplinary team. So thank you so much for your response. So in order to make sure the services is well provided, we need to work as a team. All professional, we need to work there. Everyone has a role. A pharmacist has a role. A respiratory therapist has a role in making sure this patient condition is being improving. So nobody is superior to the other. We depend on each other in order to improve patient care. Thank you so much. Kevin? So another practice change of action is to discuss the type of monitors needed in an intensive care unit. Now back to our case. Mr. T is transferred from the emergency department to the ICU after evaluation by the ICU physician. So the ICU physician evaluated the patient and decided to transfer the patient to ICU. He's placed in an isolation room with a negative pressure as a person under investigation for COVID-19. He continued oxygen therapy with a non-rebreather mask, but the flow has been increased now to 15 liters per minute. Initially it was 10, now it's 15 liters per minute. Now the question comes, which monitors should be placed on this patient? We need to discuss again on this. So what do you think the monitor should be placed on this patient? Is already now in ICU on 15 liters per minute, isolated for observation of investigation, but now we need to place some monitors. So which ones do you think are needed or can be placed in this patient at this point? Feel free to answer anything. As I say, we just take opinion because we are caring this patient. Everyone has a thought on what should be done to this patient. Now, what are the main monitors should be placed? Okay. So which monitors do you think should be placed on this patient? Andika chochote, and just feel free, Asante, and see one. Thank you, Privatus. Privatus has said pulse oximetry, BP monitor. Thank you so much. Julian Ijore, thank you. Pulse oximetry, ECG monitor. Thank you so much. Okay. Okay. I don't think there's anyone to add. Okay, Nasoro, thank you. Nasoro amesema is SpO2, blood pressure, ECG. Felix Felista, thank you so much, ECG, pulse oximeter. Okay, so all people are mentioning the basic monitors, and I think that should be done initially. As we all know, once you receive a patient who is a critical ill patient, you need to get some vital signs initial. So you need to get some initial vital signs of the patient. And those things you have mentioned. Okay, thank you so much, Raymond. Again, I have seen your answers.